Welcome to this program, the Dystonia Education Series. We are truly excited to have you join us as we get started with this journey of understanding dystonia, a unique neurological movement disorder, and affects everyone individually. As we get started, I'd like to introduce myself. I'm Dr. Apurva Zavar. I'm a neurophysical therapist and founder of Beyond Rehab. Beyond Rehab is a virtual neuro rehab and wellness clinic. We specialize in working with dystonia, Parkinson's, functional neurologic disorders, and chronic pain. You can learn more about our programs at beyondrehab.health. And I'm really excited to connect with you all and get this Dystonia Education Series program started.
Well, outside.
Program is designed to provide you with expert insight, practical guidance, and latest information to help you make informed decisions about managing your care. Throughout this series, our goal is to deepen your understanding of dystonia and to answer your questions as thoroughly as possible. Do remember, this program is educational in nature and not a substitute for personalized medical advice. We encourage you to actively participate, engage, and use this opportunity to learn as much as you can. With that, I'm pleased to introduce you to our first speaker, Dr. Khemani. Dr. Khemani is a movement disorder neurologist in Swedish with over 15 years of experience working with dystonia community. He has been instrumental in bringing this program to life, driven by a vision to empower and educate those affected by dystonia and other movement disorders. Today, Dr. Khemani will help us understand the nature of dystonia and how to navigate care options. So, welcome, Dr. Khemani. So, we'll
Sorry.
we'll get started with just the first and foremost question of how do we understand dystonia in understanding both the motor and non-motor symptoms?
Yeah, that's a great question, and I had prepared some slides, and I'll try to show them if possible. But we can also ad lib it. So, as Apurva mentioned earlier, Dr. Zawar, dystonia is a neurological disorder, and the best way to describe it is to break it down into its components. I describe dystonia as an involuntary posturing or movement of any body part due to the misfiring of certain motor brain circuits, causing abnormal muscle contractions. And this is what makes dystonia a movement disorder. So it's a lot of information. I'll try to share my slides here, and then you guys can tell me if you can see them.
Yes.
And you can see those?
Mhm.
Okay, excellent. And I'm hoping that you can see the full slide and not the presenter view, correct, Apurva?
Yes, full
Okay,
screen. Mhm.
okay, got it. Great. So let's move forward. The most common kind of dystonia that we see in our clinics is cervical dystonia. And this is basically, this manifests as an abnormal contraction of muscles in the neck, causing tilts and turns that are not typical of normal posture. And in addition to causing the tilts and the turns that are not typical of a normal posture, it can also cause a jerky tremor. It can cause pain and discomfort, but the tremor is not always noticeable in everybody. Not everybody has a tremor due to dystonia. Other features of dystonia are that it interrupts normal activity because of this abnormal tilt and turn. You're not able to participate in your usual physical activities because dystonia is disabling. Dystonia is worsened by activity and action. The more you exert yourself or the more you move, the worse dystonia gets. It is also important to recognize for the sake of treatment that dystonia involves patterned muscles, specific muscles that are firing off abnormally. These muscles are recognizable and the pattern is maintained over time unless it is treated. And also another clue is that some people develop a sensory trick or a geste antagoniste, such as holding the chin in their hand or leaning or resting their neck, or sometimes holding their finger to their chin or jaw to stabilize their neck from moving, tilting, and turning. Let's see here. As I mentioned earlier, abnormal head position, limited range of motion, and jerky tremor and pain are some of the characteristics of dystonia, and these are the sensory tricks we talked about. In addition to cervical dystonia, there are other forms of dystonia. Blepharospasm is the dystonia of the eyelids in which there is a forceful shutting of the eyes, which interferes with vision. Craniocervical dystonia. Cervical dystonia is an example of craniocervical dystonia, but there are other dystonias that affect the eyes, the facial muscles, the tongue, the jaw, and the neck. And while all of these parts are involved, the typical name that is given to the dystonia is Meige syndrome, named after, I think, a physician who had described it. Then there are task-specific dystonias, which are focal dystonias. They only happen when you're performing a very specific task, like writing. That kind of dystonia is called a writer's cramp. And then there is musician's dystonia, which is a task-specific dystonia, which affects people who are musicians. For instance, piano players can get dystonia in their fingers, which can interrupt piano playing. Trumpeters can get dystonia in their lips and jaw. That's called embouchure dystonia. That can interfere with playing the trumpet. Violinists can get dystonia in their elbow or hand that can interrupt playing the violin. And these task-specific dystonias only happen when you're performing that specific task. In terms of the distribution of dystonia anatomically, cervical dystonia, task-specific dystonias are called focal dystonias because they only involve a certain set of muscles in a certain part of the body. When multiple muscles that are connected or contiguous are involved, dystonia is called a segmental dystonia, such as dystonia affecting the neck and then maybe one arm. Multifocal dystonia is dystonia affecting multiple parts of the body that are not connected with each other, such as a cervical dystonia, and then a foot dystonia, and then a hand dystonia that could be multifocal, and generalized dystonias, which are typically seen in genetic disorders or when the brain has suffered an extensive injury. Is when many parts of the body are involved that are contiguous, head and neck, torso, arm, leg. So that's basically the distribution pattern of dystonia. What are the causes of dystonia? I think, Apurva, you had asked this in your question, so I'm going to go forward and talk about it. Is that all right? Okay. So unfortunately, the most common cause of dystonia is unknown. A majority of the cervical dystonia occurs due to an unknown cause. We don't know why, but we know that there is an interplay between the environment and our genes, which predisposes some of us to dystonia more than others. And that field, which is a very active field of research right now, is called epigenetics, the interaction between our genome and DNA and the environment. And a lot of diseases are thought to be a result of this interplay. Genetic disorders can cause dystonias, and there are genes that are identified that are very specific to specific dystonia. Acquired causes of dystonia include strokes in adults. Not everyone who has a stroke has dystonia. In fact, it's a rare occurrence, but it can be seen. And neonatal injuries or brain injuries in utero before the baby is born can cause dystonia, and one of the most common brain injuries is cerebral palsy. Neurodegenerative diseases that we see in the clinic, Parkinson's disease, corticobasal degeneration, multiple system atrophy, can also have dystonia as a primary component. And then there are certain medications that can cause dystonia, and that kind of dystonia is called tardive dystonia. Um, this is really important to talk about non-motor components of dystonia. There has been a lot of research and over the past decade and understanding that dystonia is not just a motor disorder. Unfortunately, dystonia is accompanied by mood symptoms, anxiety and depression. Most commonly, people with dystonia develop social phobia because they're embarrassed to go out in public because of their abnormal neck tilt and turn. They're afraid that they may attract a lot of unwanted attention. Dystonia can interrupt sleep because of these abnormal postures and also because of discomfort. Discomfort is a fundamental part of dystonia. And it's also been recognized that people with dystonia have more cognitive issues and fatigue than people without dystonia. And so we talked briefly about the current understanding. The model is a combination of an injury to the nervous system and a genetic predisposition, which is thought to result in dystonia and uh, caused by the misfiring of those brain circuits. And then Purvad asked me to talk a little bit about the triad model of care or multidisciplinary care. And we had been talking about this for the past year. What we are doing in our clinics currently, and particularly in Western medicine, is incomplete treatment of dystonia. We fall into a rut. Every 3 months, the patient gets Botox, and that's all that is done for years and years and years. But I think that is just part of the treatment. In order to provide holistic treatment, a multidisciplinary approach consisting of effective neurorehabilitation and education, treatment of the non-motor symptoms that we mentioned, and medical treatment with either oral or injectable medications is important. If all of these three are not done, then the care is incomplete. The long-term goal is to reduce pharmacological treatment as best as possible and increase the dosing interval so you don't get the injections every 3 months, but can maybe go 4 or 5 months without injections. But that is only possible when we adopt a multidisciplinary role. So that is really important to recognize, and we are not good at doing that. One of the reasons why our clinics are not good at doing that is we don't have the resources. In order to treat non-motor symptoms, we need mental health experts. We need people who practice, who are able to teach people mindfulness. And we need people to treat anxiety, mood, and sleep issues effectively. And we don't have those providers in a majority of the clinic because, unfortunately, our healthcare system emphasizes pharmacological treatment over everything else, which is a travesty. And I think there is a business model behind that. The lobbies are very big of the pharma companies, etc., and they're in bed with our politicians. We don't have to get political, but this is the reality. And this is not any politics. This is actually true that the American healthcare system is focused a lot on drugs rather than the holistic treatment. As a result, the Center for Medicaid Services, Medicare Services does not pay effectively for education, for psychiatric care, or psychological care, which is very important. So there is a biopsychosocial model of care that needs to be implemented in every disease, dystonia, Parkinson's disease, essential tremor, etc., which is not being done. We only treat the biology, but the psychosocial aspect is unfortunately not addressed at all because of the lack of resources and lack of payment, unfortunately. We hope in the next year, working with Apurva, working with some practitioners, working with Marissa, our social worker, we can provide some of the other things that have been missing in the treatment of dystonia that you can see on this particular slide. And then, Purva, you asked me, when should a patient see a specialist? Well, truly, if dystonia is diagnosed, it's best to see a neurologist who has a lot of experience and knowledge in the treatment of dystonia, or a movement disorders doctor, because movement disorders specialists are neurologists that have had additional training in the treatment of movement disorders such as dystonia. So that is really important, is to do your due diligence, ask around, read reviews, read the bios of physicians, etc. This is only when you know that you have dystonia. But a huge problem is the delay to diagnosis. So when you have initial signs and symptoms of dystonia, neither the patient nor their primary care doctor is able to recognize that it is dystonia. So if you don't even know that you're developing dystonia, you're not going to be able to see a specialist. You're not going to be able to know to see a specialist. So that delay in diagnosis is a huge problem. There's a huge gap in knowledge. Even movement disorder specialists do not understand dystonia fully. We just have hypotheses and theories. So I don't blame primary care doctors and general neurologists who have not been trained in dystonia to understand dystonia. It's very complex. So that knowledge gap needs to be bridged. And hence we started the Dystonia Education Series, not just for patients, but if we play our cards right, we have the resources, we get our grants, then I am interested in starting the Pacific Northwest Dystonia Education Series for physicians, PCPs, and general neurologists. That's a huge endeavor to get other physicians to be interested in dystonia, but we have to work at it. There's such a forum or such a mechanism doesn't exist, and we really need it. We talked about a little bit about education or the importance of, there are many sources of education, the Dystonia Education Series, Dystonia Medical Research Foundation, and then the importance of utilizing multidisciplinary care, or even asking that of the provider, saying, well, thank you for treating me with Botox, etc., but what about my other issues? And then, it's up to the provider to call on those resources if they're available, or work with the primary care physician. And that's the end of my slides. I think I talked more than I should have, so I'm going to stop sharing over here. I don't want to take up your meeting, Apurva. I know you and the patients over here, subjects, would like to talk about other things, but I'm happy to take a couple, 2, 3 questions and then exit.
Sure. I'd like to briefly ask you, like, how does dystonia get diagnosed?
The diagnosis of dystonia depends on the identification of all those things that I mentioned earlier. Number one, it has an involuntary abnormal posturing or positioning of a particular body part. Number two, if a jerky tremor is identified, an arrhythmic tremor, then the first clue is, it could be a dystonic tremor. Number three, it interrupts normal activity. It is worsened by activity. It is a patterned movement. And then there are sensory tricks. You have to put all of this together in order to diagnose dystonia. Hence, you have to have knowledge of the various components of dystonia in order to diagnose dystonia. Once you diagnose dystonia, then you have to answer the next question. Where is it coming from? Is this an idiopathic dystonia? 90% of the cervical dystonias in my clinic are idiopathic, cause unknown. There doesn't need to be a extensive investigation. maybe a spinal X-ray or MRI if there is other issues like radicular pain, numbness, tingling, etc., which can happen with dystonia. Um, and then the other kinds are, is there a stroke? Is there injury, etc. Those dystonias are more easily recognizable because in addition to the dystonia, the patient has other neurological and constitutional symptoms. So a savvy physician should be able to pick those up and say, oh, you know what? You have dystonia, but you've got other things going on as well. So therefore, I think we need to do an investigation for the cause of this dystonia. So that's how you diagnose dystonia. It is purely a clinical diagnosis. There is no one test available for it.
I see. Thank you. Um, Please feel free to unmute or type your questions in the chat for Dr. Khemani.
Don't see any questions. Seems it's crystal clear, everything.
Hi, my name's Amy, and I've taken a part with Dr. Zerwar before, but mine is more just a comment because it took me about almost 4 years to get diagnosed, and I really appreciate you. You're really one of the first physicians that have come on to anything that I've listened to who's been honest and really talks about how the healthcare system is set up as it stands right now. And just even that little bit, I really appreciate because I can tell you, nobody ever says that, nobody mentions that. And I, as someone who's living with this, I just really appreciated your honesty and your candor about it. So thank you for your time today.
Yeah, you're welcome. It's called School of Hard Knocks. When we come out of fellowship, we think we know everything. Within a few years, we realize we know nothing. The more we learn, the less we realize, the less we know, and that is so critical. We have to recognize the failures of our healthcare system and the knowledge gaps. Otherwise, how will we improve the quality of a patient's life? And it is really incumbent on the patients to become advocates. You must write to your senators. You must write to the CEOs of healthcares. You must write to your physicians saying, you're providing incomplete care to me. You don't have a mental health expert. How is that possible? So if you make your voices known, it will change. They will not listen to physicians because we have a conflict of interest, if you understand what I'm saying. So I would like every patient to become an advocate and talk to their community and to their politicians and their healthcare providers. We need a complete model of care. That's what I feel needs to be done.
Sure. I see this question. Where does someone get dystonia specific therapy, and in what order should someone get the therapy?
So I'll let Apurva answer what dystonia specific therapy is, but the triad is important. Neurorehabilitation and education is available, but Dr. Zawa will tell you later on that you can't just go to any physical therapist. You have to go to someone who knows dystonia, otherwise your symptoms may get worse. And as much as chiropractic is common in Washington, I am not an advocate of it for dystonia. I really don't like sudden maneuvers of the head and neck and cracking vertebrae and jolting and jerking. That is it's not good. I'm sorry to say. You can get gentle massages and all of that, but I'm not a proponent of chiropractic. I've seen some disasters. And number three, the pharmacological treatment is oral medications are not very good only because they go everywhere in the brain and then they dull you down. And they're good as a stopgap measure when other things are not working, but botulinum toxin seems to be the standard of care, and it needs to be injected in certain muscles that are strategic and identified the pattern. So where do you go for care? You go to the movement doc or the neurologist. You must go to the neuro rehab person, and then you have to address your non-motor symptoms. And that is the most complex thing, and I don't have an answer for that. Truncal dystonia is a segmental dystonia which involves the torso, and it involves many muscles of the torso. Either you get tilt, flex forward, and bend back. It's highly uncommon, and it's very difficult to treat because, as Dr. Zawar will tell you in her talk, there's so many muscles in the back. It is very difficult to treat all these muscles. I think for truncal dystonia, neurorehabilitation is a very, very good answer. But I will let Apurva talk to that if that's okay.
Sure. Yeah. Thank you. Any other questions for Dr. Khemani before he leaves?
There's a question by Nancy. Do you know of any health insurance that pays for the non-motor symptoms such as meditation, somatic work, and yoga? No, but it's interesting that I have written physical therapy referrals for massage. And somehow it's accepted by certain insurances. Yoga, no. Meditation, no. Somatic work, no. Categorically, no. These are out-of-pocket expenses, which is what makes it problematic. But Erin, Apurva, our clinic manager, Louise, it's an ongoing project. If we raise enough philanthropic money, maybe we can have providers. But Erin can tell you later how complex that is. Erin runs the Multiple Sclerosis Center of Excellence. She's part of it, so she has so much knowledge about multidisciplinary care. So Erin and Apurva can tell you more about that. And we can talk more at another Dystonia education series, but y'all talk with each other, talk to Apurva, because that's one of the most important things. And then if there are questions, and then I can answer offline, send you an email and things like that. Does that make sense?
Yeah, awesome. Thank you so much for
Then
joining.
I'll take my leave. Thank you guys. I'll talk to you later. Bye. Take care. Bye. Bye-bye.
So this was a good start. So we can use the remaining time to discuss and see what are you seeking when it comes to your care management, and if you have any questions around it.
I will also leave you all to start this group. I wanted to just peek in before it started, but since the topic of yoga came up, I wanted to let you all know that the Swedish Neuroscience Institute has virtual yoga every Tuesday at 1 and 2:30 p.m. They're 75-minute classes. So if you're interested in that, and I'll make sure that that information is sent in a follow-up email to everyone. It's free. It's provided to any of our MS, movement disorders, and other SNI clinic patients. And the instructor is wonderful. So you are all welcome to do that, totally free, and it's offered to our patients. So I will make sure that's in a follow-up email. Thank you so much.
Thank you for sharing that.